Oligohydramnios is a condition in pregnancy characterized by a reduced volume of amniotic fluid. It is commonly diagnosed on ultrasound when the amniotic fluid index is less than 5 cm or when the single deepest vertical pocket measures less than 2 centimeters. In terms of incidence, oligohydramnios occur in approximately 1 to 5% of all pregnancies. It is more frequently seen in post-term pregnancies, growth-restricted fetus, and pregnancies complicated by hypertensive disorders. Amniotic fluid is primarily produced by fetal urine after mid-pregnancy. Oligohydramnios is clinically important because amniotic fluid plays a vital role in fetal growth, lung development, and protection from cord compression. Reduced fluid volume increase the risk of fetal distress, intrauterine growth restriction, musculoskeletal deformities, pulmonary hypoplasia, and adverse perinatal outcome. So, what are causes of oligohydramnios? Causes of oligohydramnios include maternal causes, placental disorder, pregnancy-induced hypertension, essential hypertension, preeclampsia, nephropathy, illicit drug abuse, cocaine, disruption to maternal fluid state, anorexia nervosa, hyperemesis gravidarum, maternal dehydration. Fetal causes include fetal infection like Toxoplasma gonadie, rubella, cytomegalovirus, herpes simplex virus, medication use, angiotensin converting enzyme inhibitor, angiotensin receptor blocker, indomethacin, non-steroidal anti-inflammatory medications, chromosomal abnormalities, fetal structural abnormality, renal outflow obstruction, bilateral renal agenesis, pelvis ureter junction obstruction, bilateral autosomal recessive polycystic kidney disease, posterior urethral valve obstruction, Purine belly syndrome, lower urinary tract obstruction, fetal anemia, placental causes like placental insufficiency, multiple gestation like twin to twin transfusion syndrome or rupture of the membrane. Complications of oligohydramnios. Oligohydramnios is associated with several maternal and the fetal complications depending on the gestational age and underlying cause. Fetal complications include intrauterine growth restriction due to chronic placental insufficiency and fetal distress caused by umbilical cord compression. The prolonged oligohydramnios may lead to pulmonary hypoplasia, particularly when it occurs early in pregnancy, like Porter syndrome. Restricted fetal movements can result in limb deformities and contractures as well as facial compression defects. There is also an increased risk of meconium aspiration syndrome, low Apgar score, and stillbirth. Intrapartum complications include cord compression, abnormal fetal heart rate pattern, and an increased likelihood of operative delivery, such as induction of labor or caesarean section. Neonatal complication may include respiratory distress, sepsis, and the need for neonatal intensive care unit admission. Overall, oligohydramnios is associated with increased perinatal morbidity and mortality, highlighting the importance of early diagnosis, close fetal surveillance, and timely delivery. The lack of amniotic fluid lead to fetal compressions, giving rise to the characteristic Porter fascias, which include flattened nose, low-set ears, recessed chin, and epicanthal fold. Reduced fluid also restricts fetal movements, resulting in limb deformities and contracture. One of the most serious consequences of Porter syndrome is pulmonary hypoplasia, caused by inadequate lung development, which is the leading cause of the neonatal death in affected infants. This is table from the talk article for the maternal and the fetal complications of oligohydramnios that is already discussed. Evaluation of oligohydramnios began with a detailed history. Key points include reduced perception of fetal movements, history of leaking per vagina, suggesting premature rupture of membrane, maternal conditions such as hypertension, preeclampsia, diabetes, or post-dated pregnancy, drug history, especially use of ACE inhibitor or NSAIDs, and previous obstetric history of growth restriction or stillbirth should also be explored. On examination, the symphysis height is often less than expected for gestational age. Abdominal palpation may reveal easily palpable fetal parts with reduced liquor. Fetal presentation and lie should be assessed and fetal heart rate monitored. A sterile speculum examination is performed if membrane rupture is suspected. Investigations include ultrasound, which confirm the diagnosis by measuring amniotic fluid index less than 5 cm or single depressed pocket less than 2 cm. Ultrasound also assessed fetal growth, placental morphology, and congenital anomalies. Fetal well-being is monitored using non-stress testing and biophysical profile. If indicated, Doppler studies are performed to assess placental insufficiency. Management identification of the underlying cause. Investigate for causes. This may include maternal dehydration, preeclampsia, fetal growth restriction, congenital anomalies, or post-term pregnancy. Treating reversible causes such as maternal hydration can sometimes improve amniotic fluid volume. Oral or intravenous hydration may be used in mild cases, especially if maternal dehydration is suspected. Regular fetal surveillance is essential. This includes non-stress tests, biophysical profile, and Doppler studies to monitor for fetal distress or growth restriction. Increased monitoring is recommended in severe or the persistent cases. Decision on delivery depend on gestational age and the fetal status. If the pregnancy is near term or there is evidence of fetal compromise, early delivery may be indicated. In preterm cases, conservative management with close monitoring is preferred until fetal maturity is adequate. Amnio infusion is optional in selected cases, especially during labor with variable deceleration on cardiotogography. Amnio infusion can be considered to improve amniotic fluid volume and cushion the umbilical cord. Management often requires team approach, including obstetrician, maternal fetal medicine specialist, and neonatologist, ensuring both maternal safety and optimal fetal outcome. This table from talk article for guidance of the management of oligohydramnios. Thank you for your attention. We hope this presentation has been informative and helpful. Wishing you continue learning and success in your practice.